To start in that case. Good evening and welcome to this first webinar organized by the Indian Health Economics and Policy Association, IHEPA. Established almost a decade ago, IHEPA is a space where young scholars and researchers, grassroots practitioners, the private sector, and community-based organizations are encouraged to participate actively so that all views and experiences can be heard, debated, understood, and absorbed. We have a growing membership of over 240 life members, 80 student members, and several institutional members. We regularly hold an annual conference as well as a summer school for master's and PhD students working on health economics and policy issues. Today, we have gathered on this webinar to mark the birth centenary celebrations of Nobel laureate economist Kenneth J. Arrow. He was born on 23rd August 1921. The theme for today's webinar is market failures and the role of government interventions during public health crises. Our co-host for this event is the International Institute for Population Sciences, Mumbai. We would like to particularly thank Professor K.S. James and his team for supporting us and making this event possible. Let me now introduce the panelists and the moderator. Each panelist will speak for about 20 minutes, followed by an hour of question and answer and moderated discussion. Our first panelist is Professor Achin Chakraborty. Achin is a professor of economics and the director of the Institute of Development Studies, Kolkata. He received his PhD in economics from the University of California at Riverside. Earlier, he had been on the faculty of the Center for Development Studies, Trivandrum, and taught health economics at the Achyuta Menon Center for Health Sciences Studies. He has extensively written and given lectures in different forums on aspects of welfare economics, human development, and methodology of social science, and so on. He is an executive member of IHEPA's Governing Council. Our second panelist is Professor Peter C. Smith. Peter is Professor of Global Health Economics. He is a mathematics graduate from the University of Oxford and started his academic career in the Public Health Department at the University of Cambridge. He worked at the University of York for 25 years before moving to Imperial College Business School, where he is now Emeritus Professor of Health Policy. His main research interests are in finance and efficiency of health systems, with a special emphasis on the link between research, evidence, and policy. Current interests include health system modeling, measuring and improving health system productivity, and universal health coverage. With colleagues, he has published over 150 refereed papers and 14 books as author or editor. Peter has acted in numerous UK governmental advisory capacities and is currently chair of the NHS Advisory Committee on Resource Allocation. He has also advised many overseas governments and international agencies, including the World Health Organization, the International Monetary Fund, the World Bank, the Inter-American Development Bank, the Global Fund, the European Commission, and the Organization for Economic Cooperation and Development. Our third panelist is Dr. Iqbal B. Dr. Iqbal is a public health activist, a neurosurgeon, and an academic in Kerala. He is currently serving as a member of the Kerala State Planning Board. He was a member of the Kerala State Planning Board from 1996 to 2000, during which he played a vital role in People's Plan campaign, a decentralization movement by the government of Kerala since 2016. He was the Vice Chancellor of the University of Kerala during the period 2000 to 2004. He was the chairman of the Kerala State Pollution Control Board. He was the chairperson of the expert committee set up by the government of Kerala to explore the possibility of setting up a new University of Health Sciences. He is an activist of Kerala Shastra Sahitya Parishad and has held various offices in the organization. He was the president of the KSSP from 1983 to 85. He is also one of the joint conveners of the Jan Swasthya Abhiyan. Our moderator today is Professor D. Narayana. Narayana is currently the Vice President of IHEPA. He was the Director of the Gulati Institute of Finance and Taxation, Trivandrum, until last year. Prior to this, he was a Professor, Reserve Bank of India Development Studies Chair at the Center for Development Studies, Trivandrum, where he taught for about 25 years. He earned a PhD at the Indian Statistical Institute, Kolkata. He was a Fulbright Scholar at the Harvard Center for Population and Development Studies and visiting professor at Unité de Santé International, Montreal, Canada, in 2006. He was actively involved in capacity building at the level of the local governments and with women's self-help groups in Kerala. His areas of interest include health financing, decentralized governance, and healthcare services. I now invite Professor Achin Chakraborty to give his talk on health economics in uncertain times, Kenneth Arrow's legacy. Achin? Achin, we cannot hear you.
Oh, okay.
Now we can.
Yeah, okay. Thank you very much, Srilata, for this nice introduction. And as you all know, that today it's a particular event that because we are going to pay tribute to Professor Kenneth Arrow with this webinar on health issues. And as many of you know, that Kenneth Arrow is is sort of pioneer in introducing this discipline, health economics. So it's a very special event for our Indian our association, and I'll begin with basically the contributions of Kenneth Arrow and how we can make sense of that today, because Kenneth Arrow's paper 1963 in American Economic Review, and at that time, in most of the countries, the health system was very much like this individual physician meeting individual patient, and very rudimentary kind of medications and all. Not much health system thinking actually started around that time in the 60s. So, in a sense, that Kenneth Arrow's paper, in fact, triggered this what might be called health system thinking, and what are the roles of market vis-a-vis non-market institutions and things like that. So that's why it's a classic paper in health economics, and you can see that from the citations that over time, in fact, in the initial first 10 to 15 years, you couldn't see much citations, but after that actually picked up. And even today, any health economics paper, you'll find that it cites that 1963 paper by. Now, what are the things that still we think that it's very important, particularly from the vantage point of health system in a country like India, and the basically the I mean I'll just start off with the basic ideas about this market. Characteristics, and what is special about medical. Beginning of the paper, he was very clear about that. How he is concerned about medical care or health care, not health per se. So health is a very different thing. So he is basically considering healthcare or medical care. So in a sense that that paper actually looks at a particular sector which might be called healthcare sector. So today, how do you look at that the contributions of Arrow in terms of our system thinking. I mean, health system thinking. Uh, that for over the past couple of years, we have been debating this. Whether more market oriented or whether it would be entirely the public sector which would be the ideal form of provisioning of healthcare services. Now, this debate actually is going on and on, and in terms of the practical health, I mean, in terms of the actually existing health systems, if you look at countries around the world, you'll find that different health systems actually are moving back and forth. I mean, earlier, some countries actually went ahead of others in terms of public provisioning, but later on, again, they selectively they allowed sort of market elements into the health system, and the various concepts care and those kind of issues actually have come up even in the context of advanced developed countries. So know that different countries have different health systems, and the mix of public and private that also varies quite a bit, varies widely across the countries. So by health system here we mean the mix of private and public. It's not public-private partnership, which is quite fashionable in India in the recent times. But we are not talking about public-private partnership as such. We are talking about public-private mix as a system. That means in a system where there is predominantly a public system which has been there for long, and since independence, the health system thinking in India it's much more public oriented than in many other countries, and so given that kind of public oriented system thinking, now we can see that in the past couple of years, quite a few years, in fact, that there is a kind of paradigm shift in that kind of thinking, that it's a more insurance based kind of allowing market kind of system. So if you look at this trajectory of the Indian system and then try to draw on Kenneth Arrow's insight into the system, how the two. Now, healthcare. When we talk about healthcare, and particularly during this, COVID pandemic, well, most of the things that we understood as this as preventive and curative, those kind of distinctions, and so now, in fact, it's a very different way of. I mean, people have now have been looking at these things in a very different way. But traditionally we make this distinction between curative care and care, and from health economics perspective, preventive care basically it is in the nature of what is called public good. The public good, which is basically non-exclusion, non-exclusive and non-rival, and where actually it has to be. I mean, traditionally it has been provided by the state. So the things which are in the nature of public good, non-excludable and non-rival kind of good, traditionally the state actually provides that. On the other hand, there's much of the curative care actually is in the nature of private good. Private good in the sense that you can exclude someone who is not going to pay for the service. So this is excludable, and this is also rival in the sense that when you are treating 10 patients, then the 11th patient actually requires some marginal time, additional time. It will be spent on that patient. So in other words, much of curative care is basically in what economists would call private good, and much of public health or preventive or promotive kind of services are in the nature of public good. So that's a very broad distinction. But when it comes to then curative care, then further distinctions are needed. It's not that every type of curative care actually is typically it's a private good, and one has to really buy that service at a price and things like that. So that is exactly what Kenneth Arrow's contribution is. That is, he actually made it clear that the special nature of this particular service, which is called curative care, and what is the special nature of that? The special nature is that, it's basically, it's a uncertainty and asymmetry of uncertainty. Means, asymmetry between the care provider or care, even you can call it seller of care, and the buyer of care. So this asymmetry in terms of uncertainty. Now uncertainty, again, Kenneth Arrow talks about two kinds of uncertainty. One is that it's uncertainty regarding your probability of falling sick. That means, you may or may not fall sick, so there is a probability that you may fall sick. So that's one kind of uncertainty. The other kind of uncertainty is that when you go to the caregiver, when you go to the provider, then so there are basically two kinds of uncertainty that Kenneth had actually talked about. Now, so all kinds of issues, like what? Like if you leave curative care sector entirely to the market forces, then what might happen? Uh, the that would happen is that, because of this asymmetry of information, so there will be some tendency to sort of monopolize the market for each physician. That is, so competitive market actually breaks down in that case. That means each physician will have a little monopoly of his market, and so the price that he's going to charge. So there is an advantage and disadvantage of that. The advantage is that this physician actually can price discriminate, which means that the physician can charge differential prices to different patients, including the poor patient who, sometimes the physician, the doctor, in fact, treats free of cost the poor patient. So it's a kind of price discrimination, and that price discrimination is possible because each doctor actually can act as a kind of monopoly. Now, this is the kind of characteristic of curative care services, which is basically physician-based and patient-physician kind of individual patient, individual physician kind of system, which I think Kenneth Arrow had in mind at that time. But later on, what we observed is that now we have these corporate hospitals, we have different kinds of provide different kinds of players in the private market. Now, these different kinds of players in the private market. Now, how do you look at this? From this Arrow's point of view, that does his analytical or is his analytical framework still applicable in this context, in the context of corporate hospitals and things like that? I think largely it is. And but in fact, what Arrow in fact pointed out, that as a response to the failure of the market to take care of this issue, in fact, non-market institutions come up. So that is what Arrow in fact suggested, that many of the responses in the healthcare system, we see the non-market institutional responses, which could be seen as the failure of the market to allocate resources, just like any other commodity. So first of all, healthcare is not just like any other commodity. It's very different because of this asymmetry between the provider and the recipient or the buyer. And because of this asymmetry, this competitive market, which is kind of economists kind of reference point, that competitive market, and that competitive market is after all not bad. Most of the people believe that, because if there is no monopolizing tendency, then it is Pareto efficient outcome. So this medical care market deviates widely from this competitive market. So you cannot possibly see that kind of competitive market, I mean textbook kind of competitive market that you see in economics. So it is non-competitive, monopoly or oligopoly or all kinds of market forms you could see in that. And moreover, it is this pervasive informational asymmetry actually leads to this kind of market failure. So in other words, healthcare market is characterized by this market failure. So non-market institutions actually come up as a response to that. So that is Arrow's point. And he also brings in the issues of trust and norm in this particular context. That trust and norm, how trust between the patient and the doctor actually can bind them together in a trust relationship, which actually kind of avoids the problem of this failure of the market. So in other words, these different kinds of non-market. So one consequence of Arrow's paper is that we have learned how to look at the non-market institution as well. So it's not that the market institution or the market system which inevitably fails in healthcare market, but on the other hand, we have also been sensitive to the issues of non-market institutional responses to market failure. Now, what are these possible non-market institutional responses? Now, in the present context, just think about during this pandemic over the past 4 5 months, what we have been observing in Indian context is that it's extremely chaotic kind of public-private mix. The public-private mix that we have, or that we have inherited from the past before pandemic, it is completely chaotic. Chaotic in the sense that, I mean, I can see from West Bengal. I'm from West Bengal, so I can talk about this. The system in West Bengal, and it is a. I mean, there are stories every day in the newspapers. There are stories of this kind. That is, the private hospitals, in fact, just taking for a ride. I mean, the patients, they're helpless, and private hospitals, they're charging anything like 10 to 15 lakh or something for just a couple of days of hospitalization and things like that. So absolutely uncontrolled. It's a kind of profit-making kind of system that we see. I mean, which is very different from, in fact, what Kenneth so Kenneth had a thought that this market failure probably would lead to a kind of non-market orientation, where in fact this the trust and the societal norms would actually bind together the provider and the user. But that is not happening. It doesn't necessarily mean that it has to be provided by the state. So I mean, state and other non-market institutions can be distinguished in this context. It doesn't have to be the state, but largely, I mean, the state has the capacity to deal with this, and the state has the resources, and state can provide the resources. So ultimately, it boils down to the question of the state versus market. So other non-market institutions are very minimal in our context, but still you can see the difference. The difference is that we hear stories about certain hospitals which are not just typical corporate profit maximizing hospitals. They're slightly different kind of non-government hospitals. Now there are stories of those hospitals as well. So in other words, I mean, Kenneth Arrow is the first person who actually systematically looked at these different alternative possibilities, which I think that we can learn a lot from these, just by observing these actually existing alternative institutional forms, and learn from that. So I think I'll just take a couple of minutes, 2 3 minutes, and then conclude. Uh, the present context, as I said, that this extremely chaotic kind of situation, and the state governments, the way the state governments have responded, it's also extremely ad hoc and knee kind of reaction. That means today, if there is some news item in the newspapers that so such and such hospital actually has charged huge amount for a couple of days hospitalization, then immediately the state government says that no, we are going to cap it. So we are going to I mean, one hospital actually asked for advance. Unless you pay the amount in advance, not admit you. And immediately it became a news. And then again the next day the government's response was that okay, no private hospital can charge in advance. Now these are the knee-jerk reactions, and without really any kind of system thinking, just because, I mean, because it's a extremely, volatile issues and people are aggrieved about this thing. So any and every response that the governments, either at the center or the state governments, you can see that, in most cases, it's just a knee-jerk reaction without much system thinking. Now, system thinking is I would say it's a matter of practice as a habit, so we should build up that kind of system thinking where, I mean, if it is entirely public or state system, well, I mean, we have one system, but we don't have that kind of system. States have this system, like, it's a mix of private and public. So how you, I mean, a system thinker would actually look at this question, that how this, this proliferation of private healthcare providers, what would be the consequence of this proliferation of private healthcare providers, given that we already have a publicly provided this, health system. So this kind of system thinking, that is basically the interaction between the public and the private, and what it actually leads to, that would be, I think, the most valuable insight, that we can draw from Kenneth Arrow's paper. Now, interestingly, Kenneth Arrow actually didn't go back to this much. I mean, there are only 2-3 papers out there, and that was all about insurance. And Kenneth Arrow didn't write anything on medical care. But just a single paper, this 1963, in fact, has in fact generated these thousands of health economics, or the researchers got interested in that. So so later on, if there are questions, maybe we can talk about that. Okay, thank you very much. Thank you.
Thank you, Achin, for a very interesting framing of how Arrow looked at the market for healthcare. I have a quick announcement to make. Questions can be posted in the chat box, and they will be taken up at the end, after all the talks are completed. I now invite Peter to speak about optimal global distribution of a COVID-19 vaccine.
Thank you very much, Shalata. It's a pleasure to be part of this webinar, and thank you to the organisers for inviting me. Before I start, I'd like to just acknowledge, first of all, my colleagues at Imperial College. We are developing an economic optimization model, and some of the ideas I'm going to be talking about will reflect work that's being done there. And of course, the second acknowledgement I have to make is to Kenneth Arrow, who started the whole idea of health economics, which has proved so fruitful and fertile, and I might say useful a discipline for governments around the world. The final thing I wanted to say before I start is I did want to extend my sympathies to all people, all those attending this webinar, whose may have been indirectly or directly affected by this terrible virus. Now, what I'm going to slightly change the nature of my talk, because I'm going to, the title I really want to talk to is who should be the first people to get a COVID-19 vaccine when one arises. And it turns out that this is really quite a difficult question. Infectious disease poses profound challenges for conventional economics. And Achin talked about public goods. Well, I think that the issue with infectious disease is, of course, more about externalities and the fact that the behavior of others actually has a profound effect on you yourself. So that I think is the fundamental non-market issue that arises in this particular area. Secondly, the humanitarian impulse has been proved very strong under COVID, and that's something that traditionally we economists do not necessarily treat too well. There are also big political issues that have come to the fore, and fundamental ethical issues that we really need to build into our models. But I think as economists, what we have to do is to give the economic perspective whilst acknowledging that there are other perspectives as well, which may well affect the decisions of policymakers and others. So before I really jump into the meat of the paper, I just want to talk a little bit about vaccines. Of course, we've been hearing that there may be some becoming available perhaps sooner than we expected. What I'm going to assume today is that there is just a single vaccine which becomes available. It's safe and effective for all population groups. And of course, that may not be the case in reality. The level of vaccination refusal by the population is not significant, is low. Let's assume that the costs of production are low, but we do have to assume, most of the predictions assume, that the capacity for producing the vaccine is limited, and there will be a limited release of the vaccine over time, and that's what stimulates this talk. We must assume that the disease will be endemic until herd immunity is achieved, either through infection or through vaccination. So with all that in place, the issue is we want to choose who should get that vaccine at first. And so the issue immediately arises is, what is our objective in doing that? What is the social objective that we wish to maximize in order to get an optimal allocation of vaccines? What we've been assuming at Imperial, and I shall stick to that for most of the talk, is that we're trying to maximize economic output in the presence of the virus, but of course, at the same time, keeping hospital admissions under control, keeping health-related outcomes minimized, and trying to minimize the restrictions on normal life and other disruptions. So one of the things that stimulated this question was the proposal by WHO and Gavi to create what's called a COVAX facility. And this is an international effort which most countries have signed up to, with one or two notable exceptions, which has the goal of delivering 2 billion doses of safe, effective vaccines that have passed regulatory approval by the end of 2021. 2 billion doses, and the proposal is that all the member states of that initiative will receive enough doses to cover 20% of their population, regardless of the economic or other characteristics of the country. Now that seems to be a very noble achievement in a way, because it does mean a redistribution of finances from rich countries to poor countries. But at the same time, it's a very crude distribution mechanism, which I'm sure we can do better with a bit more careful modeling. So first of all, I want to talk about vaccination within a country and not consider the international issue at first. So let's assume a single country with a fixed supply of vaccine, say a fixed amount per month. And of course, policymakers have a limited set of criteria they can apply to who gets that vaccine. Of course, they could just have a lottery or random. They could, of course, give the vaccine to those who shout loudest or pay most. But it's much more likely that countries will want to apply some sort of rationing device based on criteria such as the age, the medical vulnerability of patients, of the population, the occupation group, perhaps, or the area of residence. And so I will talk a little bit about some of those groups in a second, but those are the sorts of decision variables, criteria, that a government's likely to want to apply. So what are the consequences for applying this vaccine to different groups? Well, we would expect there will, of course, be health consequences in reducing the transmission and of the disease. There will be behavioral responses. It may be, for example, that if there is more vaccination in a population, people will relax their social distancing and wearing masks. So that to some extent, the increased immunity may be dampened by the fact that people stop the prevention mechanisms that have been in place up to now. And of course, there will be economic consequences. It will be possible to have, on the supply side, more economic production because of vaccination. And on the demand side, there's likely to be increased demand for goods and services. So let's just think about some of these groups that might be amongst those that are targeted by a vaccination policy. First of all, old people. Old people, all the evidence is that old people are highly vulnerable. And so any vaccine for that group will directly save the lives of that group. It will ease pressure on the health system by reducing the number of hospital admissions, for example. But it will be relatively modest life years saved because in vaccinating old people, of course, they have relatively fewer years to live. Also, this is actually, to some extent, a big issue in high-income countries. For some of these criteria, I'm going to cite the proportion of people who qualify in different groups and in different types of country. For example, population age 65 plus, 18% of high-income countries are age 65 plus. But in lower income countries, the proportion goes down to 3.3%. And India, I understand, has 6.2% age 65 plus. So high income countries have 3 times the rate of older population than India. Second group of people we might target are those with underlying health conditions. This will have the same sort of effect as vaccinating older people, but it may possibly be better targeted. We may get more life years saved, but there is a problem in specifying who qualifies. For example, if we specify COPD as one of the criteria, the definition of that may not be clear-cut, and there may be argument. I've just taken one metric of vulnerable people, which is overweight, the proportion of population that's overweight. In high-income countries, believe it or not, 58% of the population are overweight, whereas, of course, it's much lower than that in many low-income countries. And India, particularly healthy population from this perspective, less than 20% overweight. Another group that we might wish to target are, paradoxically, young people, even schools. Of course, by vaccinating younger people, we may be able to improve their educational chances. Young people mix socially a lot and therefore are at high risk of transmitting the disease. And we therefore might reduce the need for quarantine amongst families and reduce childcare needs, which of course improves labour supply because parents can now are released to go and work in the economy. Another group we might target, WHO is particularly keen on targeting healthcare workers. Of course, healthcare workers, because they are dealing with people with disease, have a high transmission risk. If they are unable to work, either because they're sick or because they're in quarantine, we reduce effectively the labour supply in the health sector, and therefore reduce our capacity to look after people. Again, I'm sure you're all aware that the variations in healthcare spending amongst countries is absolutely enormous, with high-income countries spending 100 times as much as low-income countries. And if we look at doctors and nurses in high-income countries, there are 14 per 1,000 health professionals in the countries, whereas, for example, in India, the figure is 2.5. So 2.5 as against 14 per 1,000. So very big differences in the number of people that would qualify if we targeted healthcare workers. Other groups we might look at, other key workers to facilitate economic security, for example, key workers in water supply, food supply, maybe telecommunications. We want to maintain their labour supply, reduce the need for quarantine, and so on. We might want to target geographically specific groups if with a vaccine. If, for example, we want to target cities or regions with particularly high levels of disease, it may be that we would want to target the vaccines there, which has, of course, some interesting issues about moral hazard in areas with poor performance on controlling COVID may be qualifying for the vaccine. That doesn't seem quite right, but nevertheless, it may be optimal. Big concern for at targeting poorer people. Poorer people have multiple vulnerabilities, poor living conditions, they live in cramped conditions, and therefore they are much more likely to spread the virus and with dangers for the entire population. So there's both a humanitarian and an efficiency issue about targeting poorer people. And one final thing, which just for completeness I mentioned, is of course that some people may argue that we should target richer people with the vaccine for two main reasons. One is they would increase economic activity, they would spend more and therefore stimulate the economy. And also we could recoup user fees, high user fees from high-income group. Now, I must underline that I am not in any way advocating targeting richer people with a limited supply of vaccine, but nevertheless, it is one possibility, and I'm sure those with who are very keen on market solutions to problems may well start advocating that. So I leave it at that. So with all those things in mind, what would a national optimization model look like? We would need to decide on the decision variables. Well, it would probably be something like what proportion of each social group to vaccinate at what time. We'd need to choose an objective function. I would suggest national GDP as being, improving the national GDP as being the sensible objective function. We found that very useful in our modelling up to now. But then we must put in place all the constraints that that hinder achievement of that objective. Economic constraints, which sectors of the economy should we prioritise? That's been the focus of our work so far at Imperial. different sectors have different levels of workforce and human contact. They have different levels of demand for their goods after COVID, and supply chains. We've got to make sure that if certain parts of the economy open, they actually have all the inputs they need. It is, for example, no use opening bars if the breweries are closed and there's no beer. So that's the economic constraints. Health service constraints we need to apply. What is the limit on the number of hospital beds and equipment we've got, the skilled workforce needed? So a lot of health system constraints that we have to apply. And then most importantly, we've got all the epidemiological constraints. We have to model the disease dynamics. The epidemiologists do a superb job here. We have to model the quarantine of close contacts to someone who is diagnosed. We have to have the severe cases admitted to hospital if we have the capacity. We have to model the consequent deaths and disability caused by the disease amongst different groups. And then we've been modeling different rates of transmission within different sectors, transport, the service sectors, the schools, the health services, and so on, in order to put all these things together so that we can decide where that vaccination is best deployed, so that basically the marginal benefit of a vaccination is satisfactory wherever it's deployed. So that's the rudiments of our model. The model will reduce the vaccination will reduce transmission among some groups, reduce the associated illness, death, and use of self-services amongst those groups, and of course their contacts. It will reduce the need for quarantine, other mitigation strategies, reduce the need for family carers looking after children or old people, for example, and therefore increase labour supply, improve economic productivity, and so on. But note, I did mention this possibility that there will be adverse behavioural consequences of a vaccine if it means that people are not distancing as well as they were before. So I'm running out of time, so I'm going to have to really run through the rest of this talk very quickly. If we're to optimize international distribution of a vaccine, we need to think about the consequences for individual nations of allocating them a vaccine. And doing that, we need to think about what the objective is. Is it health? Is it GDP? Or is it simply global solidarity? And that's certainly what COVAX, I think, is doing at the moment in giving equal amounts to every country in proposing that. Come what may, I think a market solution is highly unlikely to be optimal either locally or globally. Any global solution is likely to require high-income countries to voluntarily give up some, even up to 80% of their entitlement to vaccines that they've purchased through purchasing agreements. And I think there's little incentive for high-income countries to support lower-income countries through just bilateral agreements. It's a sort of prisoner's dilemma because high-income countries have an incentive to free ride on other countries being humanitarian. So we do need something like the COVAX solution, a collective global solution in which high-income countries participate and they support low-income countries. In conclusion, I think this is an immensely complex optimization problem at both national and international level. But I do think it's probably tractable, but it's only workable and it will only be realistic if economists work with others, epidemiologists, ethicists, political scientists, and so on. And we also need to work with experts in individual countries, because while the disease has predictable trajectories everywhere, countries have very different economies, health systems, and social preferences. So our first efforts at optimizing economic activity whilst keeping within health service constraints will be published soon on the Imperial College, with Imperial College colleagues on their website. But so far, we haven't put vaccination into that model. But our next step is to try and do that. And we look forward very much to having feedback on that and finding ways from everyone about how we might improve our efforts. So thanks again very much for the invitation to this webinar. I've enjoyed being part of it very much.
Peter, thank you so much for that very interesting talk, unpacking the complexities associated with vaccine distribution. Let me make again an announcement to participants to please post their questions in the chat box as we move along. And now I would like to invite Dr. Iqbal to discuss the issue of the role of local self-government institutions and COVID-19 control in Kerala.
To be with you this evening to discuss with you the role of the local self-government institutions in controlling COVID in the state of Kerala. Before that, I have to necessarily mention that I am extremely happy to participate in this webinar due to various reasons. The foremost being that as a practicing clinician, as well as a health activist, I always felt that an exposure to health economics is a prerequisite to be an efficient clinician as well as an effective public health activist. And I was very fortunate to come across with the Indian Health Economics and Policy Association last year. I, in fact, participated in one of the seminars organized by the association in the Gujarati Institute of Taxation at Trivandrum. And I am very thankful to Dr. B. Narayana for associating me with this organization. And also I am very happy that this is organized in memory of Kenneth Arrow, who was always advocating the improvement of the public health system across the world, and that is what we are all striving for. What I have to talk about here is about the COVID control in Kerala state and the role played by the local self-government institutions. As you know, Kerala is one of the Indian states where we could manage the COVID fairly well so far. And even though a number of the cases are increasing now, but we are confident that we will be able to contain this pandemic in Kerala effectively. Even now, even though the number of cases, positive cases are increasing, we have the lowest mortality rate in India, around about 0.3%. And the local self-government institutions have played a major role in effectively controlling the epidemic here. In fact, the two factors which helped us to control the epidemic in Kerala are: one is the robust public health system, and secondly, the vibrant local self-government institutions. And this is also a very opportune time to discuss about the local self-government institutions, because, as you know, following the 73rd and 74th constitutional amendment, the first batch of local self-government of functionaries took office in 1995. That means that 25 years, a quarter of century has passed since the advent of the local self-government institutions as per the constitutional amendment. And in Kerala, a lot of discussions are going on, evaluating our experience of local self-government institutions in Kerala over the last 25 years. And if you look at the way the 73rd and 74th amendments were implemented in Kerala and how the local self-government institutions were organized in Kerala, it was qualitatively different from other states. Because you know that when in 1995 the first the elections were held and the local self-government functionaries came to assume office. But they have a difficulty because you know that the Panchayati Raj institutions are expected to hold Gram Sabhas where they have to assess the aspirations of the people, and but they could not realize these aspirations because they did not have the fund enough to do that. But what we did in the 1996 government that came to power made a qualitative change, jump in the way the local self-government institutions were functioning in compared to other states. What was done as part of the People's Campaign for Decentralization that was initiated from the planning board, and I was also a member of the state planning board at that time, and the leadership was given by the present finance minister, Dr. Thomas Isaac, who was also a member of the planning board at that time. The qualitative difference, the uniqueness of the Kerala local self-government initiative of the People's Campaign for Decentralization was that if you look at the constitutional amendment, you see that a large number of administrative functions were transferred to the local self-government institutions. But they hardly had any fund to realize the aspirations of the people, which they have necessarily to listen to when they conduct the Gram Sabhas and the Ward Sabhas in the corporations and municipalities. What we did here was a revolutionary step. If you look at it that way, is that about 25 to 30% of the state plan fund was transferred to the local self-government institutions. If you look at the last year figure, we have transferred about 26% of the state budget amount to the local self-government institutions. So funds were made available. And not only that, they were given the right and responsibility to spend this money based upon local, to understand the local level issues, and they can spend the money as per local level planning also. So planning also was decentralized. So you see that the uniqueness of local self-government institution here is that we decentralized not only the administrative decentralization, there was a decentralization of finances as well as decentralization of planning that was also done. Actually, many people doubted whether the local self-government institutions are capable of local level planning, but last 25 years of experience shows that they could do it easily. So this was what was done in Kerala. And if you look at the way we decentralized various sectors, the major decentralization happened in the field of health. In fact, from primary healthcare centers to the district hospitals were transferred to local self-government institutions. This is a very remarkable form of decentralization. And as you know that decentralization of healthcare institutions or decentralization in health has always been a controversial issue. There were those who argued that decentralization may in fact harm the health institutions, public health institutions, in that decentralization may weaken the health ministry, either the national health ministry or the state health ministry. And there were many who thought that the local self-government institutions may behave in a very anarchic manner, so much so that the national health policy or state health policy may be weakened, or they may even act diametrically opposed to the spirit of the health policy at the national and state level. And thirdly, and more pointedly, many pointed out that, especially this has to be mentioned since this is a memory, this webinar is organized in honor of Kenneth Arrow. That many suspected that this may lead to private-public participation or even a privatization of the public health system. This was some of the arguments that were, some of the debates that were happening when we talk about decentralization in health. But nevertheless, there is a very important document published by World Health Organization in 1993, which has gone, I think, very largely unnoticed. It's a very important document wherein they were arguing that if you want to improve the public health healthcare institutions, especially in the developing part of the world, you will have to ensure community participation. And to ensure community participation, what you will have to do necessarily is to decentralize the management, the funding, as well as planning. In fact, they were actually advocating what we have done in Kerala in 1996. Even though we never noticed this document, in fact, I read this document after we implemented the People's Campaign for Decentralized Planning. So the WHO advocate that to ensure community participation, you will have to decentralize not only the administrative decentralization but also planning, as well as in terms of making available state funds to the local self-government. That is exactly what we have done. And therefore, what we happened is that if you look at the 1996 situation in Kerala, you see that the Kerala public health institutions were stagnating at that time. In fact, the morbidity was increasing in Kerala, both the morbidity due to infectious diseases as well as due to the non-communicable disease were increasing, because Kerala is a highly morbid state. But the public health institutions were stagnating so much so that in that vacuum, the private sector came in a big way in Kerala. So with the result that 70% of the healthcare was provided by the private sector, and naturally the health expenditure increased, and therefore many of the low-income group were marginalized, and they had no access to healthcare in Kerala. And in fact, this was happening in 1996. So, but then the decentralization of healthcare has completely changed the situation, and the public health institution from primary health care up to district hospitals, their functioning improved tremendously because they have been transferred to local self-government institution, and health ministry concentrated on the tertiary health centers like the medical colleges, and therefore and their function is also improved. With the result that if you look at the figures, latest figures from national statistics, you see that at present from 28% there is a big jump. 48.7% of the people are utilizing the public health institutions in Kerala. So that is the major reason. And the community participation was ensured because the local self-government institutions are acting as a link between a hand-holding between the public health institutions and the social capital in Kerala. The social organizations, the major capital in Kerala, like the non-governmental organizations, the self-help group like Kudumbashree, which there are 4 million Kudumbashree members in Kerala. They are low-income women self-help groups, and there are large number of community charity organizations in Kerala, science movements in Kerala, voluntary groups, religious groups, political parties, trade unions. So the local self-government institutions are in fact having a linkage between the public health institutions and the social organizations, and therefore what is happening is that the functioning of the social capital itself get amplified to the extent that they all cooperate with the government to strengthen the public health institution. That is exactly what has happened in Kerala, and this has come in handy when we are not only we are managing the routine health challenges like management of diseases and health education, health promotion, etc., but also in disasters. And Kerala had faced this disaster in 2018. The flood came, around 500 people died, and then 2019 also there was a flood. Floods affected Kerala. Even very recently, we lost more than around 60 people in the recent flood also. So it is in this situation, you know that if you look at the flood situation in the experience in other states and other countries, you say that large number of people die of infectious disease following a flood rather than because of the flood per se. And this has not happened in Kerala because with the effective intervention of local self-government institutions, we could control the by health education and preventive measures, water purification attempts, and vector control, etc. There were a very few deaths due to infectious disease following the flood in 2018 in Kerala. And following that, we were expecting such disasters in future. And therefore, the state government has further strengthened the local self-government institutions by devolving certain responsibility to them, like disaster management at local level. So they were given the responsibility to do vulnerability studies at local level, then various type of mapping of vulnerable areas, and training was given to the local self-government functionaries, the elected representatives as well as the officials in managing disasters at the local level. So they were very well trained in disaster management planning at the local level when the COVID came to Kerala also. In fact, the first case was reported in 2020, January 30th. In fact, that is the first case in India was reported in Kerala. Because large number of students were studying in Wuhan Medical College in Kerala. And so we expected that. So we prepared for that. And if you look at the way we controlled the COVID, based upon, of course, global standards and protocols and guidelines set by World Health Organization, Center for Disease Control at the global level, or by the Indian Council of Medical Research at the national level, you see that there are certain ways in which you try to control this pandemic. One of the most, and in all these, the local self-governments were very much involved. It's because of their involvement that the health department could carry out these protocols very effectively and control the pandemic in Kerala. And if I mention a few of them, one is that contact tracing. The people come from outside, if they have got symptoms, they test them, and then we treat them. So testing, isolation, and treatment is the first step. And secondly, those who are come in contact with the positive cases who come from outside are to be traced. This is contact tracing. This is a very important part of controlment of this pandemic. It's not a very simple thing. It's extremely unless we have a community involvement, community participation, this type of contact tracing is difficult. And contact tracing was very effectively done in Kerala. And you know that for a single positive case, we traced up to an average of 100 persons, and these persons were quarantined. And quarantine was done at two levels. One is at the institutional quarantine and at home quarantine. And institutional quarantine setups, the arrangements were made by the local self-government institutions. And then when they are subjected to home quarantine, their needs are to be met. They have to be followed up. They have to be monitored. This also was done by the local self-government institutions by forming ward-level committees where the police force, the ASHA workers, the Kutumbashri activists, voluntary workers all participated, but the leadership was given by the local self-government institutions. Then the second and most important responsibility that was carried out by local self-government institution is that of reverse quarantine. Reverse quarantine means that to ensure home quarantine of the risk group people, that is those who are the elderly people, because you know that the mortality happens when death happens when COVID affects the elderly people, those 65 years, and those with comorbidity, other morbidities like cardiovascular disease or diabetes, hypertension, cancers, and various types of other diseases. Only when then the death happens. So therefore, what we have to protect this group, they have to be quarantined. This is called reverse quarantine. And when they go for a reverse quarantine, they may have so many other requirements, like they may have their medicine, because they are already suffering from various diseases. Medicines will have to be provided, and they will have to be given psychosocial support, etc., etc. This has been ensured, and it is because of the effective implementation of reverse quarantine that Kerala, in spite of having a high percentage of this risk group in Kerala compared to other states, we could minimize the mortality. It stands at about 0.3% at present. This is because of the effective involvement of the local self-government institutions. Now, there are and also local self-government institutions also get involved in the management of cases. The positive cases are now, we have classified into two groups. One is the severe cases, which will have to be managed at the COVID hospitals. The COVID hospitals are mainly are organized in the medical colleges and the tertiary care centers, but less severe cases are managed in COVID first line treatment centers, the CFLPC that is called. These are COVID first line treatment centers. And these first line COVID treatment centers are now being organized and set by the local self-government institutions. It is not very simple because they will have to be provided with various facilities. They will have to be monitored. They will have to be provided with free foods, and they will have to there the wastage because this is a biomedical wastage will have to be managed. All these are done very effectively by local self-government institutions. Now, in COVID management, COVID is not only a social and a medical issue; it's also a socio-economic issue. Large number of marginal people, because of lockdown, and also because of when they are tested positive, they may not be able to carry out their economic activities, and therefore they will have to be provided with the support. And this is done very effectively by the local self-government institutions. You know that they have organized community kitchens. They have provided, in fact, during the lockdown period, along with the industry self-help group, they have organized the community kitchens across the state and given free food or food at very subsidized rate to the needy people. And also another group which have been very well taken care of by the local self-government institutions were the migrant laborers. We call them guest workers in Kerala. We call them guest workers. And you know that because when the lockdown was announced by the central government, all of a sudden, one group who suffered most were the migrant workers. So that migrant workers have no facility to move to their respective states, and they have to walk along railway lines, roads. In fact, this type of this migration of migrant workers to their states by food, in fact, reminded us of the movement between Pakistan and India during the partition period. So that did not happen in Kerala because they were provided with residential facilities, and they were foods were given free of cost, and they were taken care of, and they were very safely transferred to their respective states when the rail traffic was re-established. So therefore you see that the local self-government institutions worked hand in hand with the health department to control the COVID situation in Kerala. And they could do this because of this, the unique type of decentralization of healthcare that has happened in Kerala. Because we have provided with them with funds. They were given the responsibility for local level planning, taking into consideration people's aspirations at the local level. And more important than factor is that the community participation is a prerequisite, an essential part of strengthening of public health facilities was ensured. I have to present about the local self-government institutions' role in control of COVID. Thank you.
Thank you, Dr. Iqbal, for giving us a very detailed and interesting insight into decentralization in the health sector in Kerala. I will now pass this on to Professor Narayana to address the questions that have come up in the course of this discussion. Thank you.
Thank you, Srilata. Thanks a lot, Professor Achin, Peter, and Iqbal. Now, let me first of all say it was heartening to hear Dr. Iqbal say that exposure to health economics is a prerequisite to clinicians. I could say the same about health policy makers. In fact, what Achin mentioned, and I think Peter also, I think reminds me of the need for more exposure to health economics for policymakers. In fact, we see that all around, the lack of that exposure. So thank you very much, Dr. Iqbal, for mentioning that. I think it is very timely, and coming from a clinician, I think it is very apt. See, if we say that, it may not make much sense. So thank you very much. Now, Achin, Professor Achin, are you able to hear me?
Yes, yes,
Hello?
yes, yes.
Yeah, Achin, there are
Questions.
half a
There are
dozen
some questions.
questions.
Yeah.
Yeah, let me read out a few.
Mhm.
Now, of course, the first question is a more general sort of a question. The question is, health emergencies, shouldn't it be systematically monitored and provided by government, or prices of private services regulated? Shall I read out all the questions, or
No,
that
no,
would be
no.
better?
Yeah, just yeah.
Yeah. And the second is, in fact, there's a very specific question.
Mhm.
Isn't seller as a monopolist a good idea? Because you can, discriminate prices. So isn't it a good idea? That's the second question. Now, you see, there's a third very interesting question. That is, while health insurance has been in existence for a while in India, and what you find is that governments still do not have adequate capacity for price fixing. How will they regulate prices in COVID era? Prices charged by the private sector, COVID era, because in the general sort of thing, though you have been having a health insurance, fixing prices for private service is still at a very rudimentary stage. That's the third question. The fourth, now failure in taking care of, this is also a question I think which we address to Peter later. That is failure in taking care of care home and elderly in UK and Italy. The question is, why doesn't it become a public priority to take care of people at care homes and elderly? Now, the fifth question is, governments in India, many state governments started sponsoring COVID insurance. What would be its effect on public health systems? I think I'll stop there. There are some questions which are all related to this, but these are, I think, the 4 or 5 main questions. Ajit.
Yeah, I think that several questions are on health insurance related issues, and I'll put them together and give my answer to that. You see that again. I mean, I would again like to go back to Kenneth Arrow, because much of the paper actually is discussion on insurance, and insurance market, we know that it suffers from, again, asymmetry of information. I mean, asymmetry of information is something which we first learned from Kenneth Arrow's paper, and we know that how insurance market failure happens because there's because of the problems of moral hazard and adverse selection. And wherever, US system, wherever you have this insurance-based system and private provider, you have this problem of, on the one hand, you have this problem of cost escalation. On the other, you have this problem of, exclusion. That is, a good part of the population is excluded from the benefit of health insurance. So we know that the bad side of this insurance and private provider, that kind of model. But in Indian context, all of a sudden, that is new wisdom actually. It is heavily tilted towards that kind of system, which is already we exposed, and we know that it cannot take care of health emergencies. So health emergencies, again, I mean, it's largely the state responds to that health emergencies, any kind of health emergency. So private sector is not to be relied on, and that we have seen from our experience. So you see, ultimately, it boils down to, I mean, no matter whether it's a kind of pandemic like this COVID situation, or it is in any kind of health emergency, I think ultimately one has to rely on a kind of elaborate system of public health system, including that preventive and promotive kind of system. So in other words, this health insurance as a solution, it is as a response. It's a political response kind of demand from a section of the middle class, which actually started going to these private hospitals and ended up spending a lot of money on private hospitals. So it's a kind of this out of pocket expenditure and all. So just by so as a response to that, the state came up with this idea that okay, so we are going to cover that up to 5 lakh and things like that. So in other words, this nationally sponsored private insurance company contracted. Now, this kind of system has to be studied. And the state, if the state finds that the public health centers, public health facilities, the state cannot control, cannot manage because of lack of capacity, then how come the same state has the capacity to regulate all these parties? I mean, all private providers, private insurance companies. The state is supposed to negotiate with them and regulate them thoroughly. Now, so on the one hand, the state is not capable of running the public health institutions, but at the same time, the state is perfectly capable of handling these kind of contractual sort of systems. The state. So I think a thorough political economy analysis is needed to address some of these questions. That why is it that this new sort of kind of paradigm shift from largely publicly provided services to a kind of insurance based private provider kind of system. So we don't have much time to discuss about that, but that would be my response. Thank you very much.
Thank you, Ajin. Now, Peter, there are 2-3 questions. One of them, which I actually asked Achin, and it's actually a common question, that is failure to take care of care homes and vulnerable in UK and Italy. Now, why hasn't it become a public priority? This is another question. Peter, am I audible? Hello.
Oh, yep. Yes, I can hear you. Would you like me to?
Yeah, that's the first question. That is, why is it that care homes and vulnerable have not become a public priority in UK and Italy? Now, the second question is, especially somebody is referring to the Indian case. We seem to be reaching herd immunity more rapidly than vaccine. Then, how do you prioritize vaccination? Because that's a new dimension. Because you listed a number of target groups, and then but when you have this herd immunity in a number of population groups, how do you prioritize? That is the second. Then there is a question of the vaccination, whether it is 1 dose, 2 dose, 3 dose, or does it protect you for life? If not, then what do you do? I think that is the sort of a third question. I think that's all I could group some of these questions into these 3. So, Peter, the floor is for you.
Thank you very much. Maybe I could start by not answering any of those questions. I will come to them in due course. But just to underline what Achin has just said, I think basically society has to make a choice about whether ill health is something you have to deal with yourself as an individual, or whether society is prepared to help you either completely or somewhat because of your ill health. And what Arrow was saying, I think, is that it is just not optimal for all sorts of reasons for people to be left on their own to deal with ill health, either because they're too poor to do anything about it, or because they do not have the money to do anything about it. And so I think that's an absolutely profound reason why universal health coverage has become so attractive to policymakers and so on. It does, quite frankly, it seems to be the optimal approach, which is to have some sort of universal insurance for all citizens, which creates entitlements. And of course, what you're entitled to will have to be limited by what the nation can afford, by how much it's prepared to transfer to the health sector. But nevertheless, I think it can be shown quite easily that that is a socially optimal solution compared to the free market, you are on your own sort of society. So I just wanted to underline that fact because this is about Kenneth Arrow and you know, his important contribution. So to actually address these questions, first of all, why are care homes, why have they not been a priority? To be quite honest, I think this is a political economy sort of issue rather than an economic one. I think care homes have traditionally in countries like UK and Italy have been places without economic power. If you think that many governments now spend a lot of time listening to focus groups and so on, those focus groups, generally speaking, will not have representatives from care homes in them, and they do not get the attention they deserve. And the other thing is, we have a centralized National Health Service, and within that National Health Service, the social care sector has traditionally been very weakly represented. I have been to numerous meetings in UK policymakers where people are talking about the health services and no one speaks up for the social care sector, which is so interlinked with the health sector. And in fact, from time to time, I've adopted that role. I have no expertise in social care, but I've adopted that role just to ask the question, what are we doing about them? So I think that's a political failure, and it's something that if there is, you know, one of these small benefits that comes out of the COVID crisis, maybe that countries with big social care sectors actually start to pay some attention to it and treat it with the seriousness it deserves. So yes, herd immunity is an interesting issue. My understanding is that we need to get up to about 60% in any population to approach herd immunity, at least 60% of the population, either with immunity, either from the vaccine or from having contracted the disease. So that's another consideration, of course, because you don't want to vaccinate people who are already immune. And there may be groups where there's a high degree of infection already. And so those should not be a priority for further vaccination. So yeah, that's an additional issue. I did actually try to seek out the data by country as to which countries had the highest rates of immunity through the spread of the disease already. And unfortunately, I couldn't. Some people have done the calculations, but they are not in a fit state to present to a group like this. But my understanding is that most countries, that percentage is still quite small. There are very few countries which are reaching anything like herd immunity. And the third issue was about the type of vaccine and the various considerations in modeling the vaccination strategy. And of course, this is terribly important because for all sorts of reasons. For example, a vaccine may be not effective or indeed dangerous for certain groups, for example, the elderly or the sick. As one of your questioners has mentioned, a vaccine may be effective only for a short period, 1 or 2 years perhaps. And all of these things, when it becomes clear what the nature of the vaccine is, they will have to be modeled. And they may well change our our priorities quite considerably when we begin to see what a vaccine will look like. And of course, not only that, there will be new, even though there will be a first generation vaccine that we apply in the short term, there will of course be new ones that come along that may have increased effectiveness, may have fewer side effects, and may be cheaper. So I think there are some very important issues that should be included in any modelling exercise about the nature of the vaccine. But of course, at this stage, we just don't know what the nature of the vaccine will be. So at this stage, we're just trying to create a modelling infrastructure that would enable us to test out these alternatives when it becomes clear what the big issues are. So yeah, thank you for those questions. Very probing and very interesting questions.
Peter, I have one more question. Since you talked about care homes and you said at the end of it, it's a political economy. Now, isn't that applicable to the vaccination priority also? Because at the end of it, it's a political decision. Because you may have, you listed a number of those vulnerable groups, but then you may have regions which are politically very, very decisive. So whoever is taking a decision is caught between these two. So how do you bring that into your modeling at any stage?
Well, I think, of course, we can show what the impact of any decision is. And we can show how far that falls short of being optimal. So we can show politicians who, let me be clear, politicians are the legitimate, well, in most countries, they are the legitimate decision makers, and that is their job to make these decisions.
Yes.
But as economists, what we can do is to demonstrate the implications of their decisions. So if their decision will mean that the economy will lose 5% compared to what it could do if they chose a better decision, then the population needs to know that so they can hold their politicians to account. So I'm not dispirited at all about the fact that politicians will not implement our results. In fact, to be quite frank, I've got so much experience of that I'm almost immune to it. But it is our job as economists to demonstrate the consequences of those suboptimal decisions so that people, and of course there are often good reasons why politicians will diverge from what economists and others are recommending, but we can demonstrate what the implications of that are. And that's, I think, our role in these circumstances.
Thank you. Thank you very much, Peter. So now I move on to Iqbal. Iqbal, there are not too many questions, but there is appreciation. So there's one solid question. Now, you see, they say Kerala model is now most popular. How did you control the pandemic in the initial stages? Because Kerala was modeled as, talked about as a model for the others and all that. So the question is, how did you control the pandemic in the initial stages? The second question is, this whole thing about social capital. Can you elaborate it further? That's the second question. Dr. Iqbal.
Personally, I don't use the term Kerala model at all or anything. I would rather say, as Amartya Sen said, Kerala experience in various things. Because I think a large number of other states also have fairly controlled COVID, in spite of having a very weak public health system. It's a bit surprising, but we'll have to examine it further. Now, Kerala could manage because we had an experience with the management of Nipah in 2018. This was an infectious disease that came to only 2 districts in Kerala, in Malappuram and Calicut. But we learned about index case, contact tracing, quarantine, even masking, etc. during that episode of Nipah in Calicut. That was a learning experience for us. Also, during the flood season, we also had some experience in controlling the infectious diseases. So therefore, Kerala had this learning experience of controlling infectious diseases because of the Nipah epidemic as well as the flood situation. See, Wuhan was not known to many outside China earlier, but Wuhan was a very familiar city in Kerala because the large number of people, students from Kerala were studying in Wuhan Medical College. And therefore, we expected that these students are likely to come. So early preparedness was another reason why we could manage this fairly well. So before the Wuhan, students from Wuhan people came, we strengthened the screening at the airports. We have only 2 or 3 well-functioning airports in Kerala. And based upon the WHO recommendations and other world experience, we have prepared the protocols for management of COVID cases. All these facilities were set in Kerala before actually the first case compared to many other states. Now coming to the social capital, you see that in Kerala, various sections of the people are fairly well organized. We have a well-organized trade unions, we have youth movements, we have various types of science movements. I am also part of the Kerala Shastra Sahitya Parishad, which is a grassroots level science movement in Kerala. And so you see that, and our self-help group, Kudumbashree, is very well organized, about 4 million people. And if you look at the ASHA workers, of course, ASHA workers are there in other states also. It's a national program. But our ASHA workers are very well educated because the education status of Kerala is very high. Even though the minimum qualification for them may be very minimal, our ASHA workers may be a postgraduate or even a PhD holder, maybe because of unemployment situation, but nevertheless, they are very well educated. So therefore, you see that there are large number of non-government organizations, philanthropic organizations, religious movements, trade union movements, political parties, all these are there. See, and in a time of crisis, they come together. But there should be an agency to join them together and direct them for appropriate action. That part is done by the local self-government. So that is why I said the social capital has been amplified by the local self-government. Thank you.
Yeah, then there is a question on the resources for the resource flow into the local governments. In fact, whether they get corporate sector donations or others and things of that sort. I think if you permit me, Iqbal, I think I will answer that question.
Better than me.
Yeah.
So you can answer that question, yes.
First, let me, local governments didn't get money from the corporate sector directly, but there were many donors. Many individuals did, donate money, and especially for the community kitchen and, that sort of a thing. But
some get a CSR funding. Some get CSR.
Yeah, yes, but they're not really very much.
Not very.
But
Yes.
individual contributions, there was quite a bit from different parts. Here, I think the experience of our floods did play a part, because during the floods also, there was a lot of that individual effort and individual contribution. So, but more than that, in fact, the point that you mentioned about the social capital, especially the Kudumbashree, now you see the community kitchens, once the decision was taken, I think within 2 days, we had about 1,000 community kitchens opened.
Yeah.
I don't think that's possible anywhere else. That's the of the social capital. Then about the funds, you see, one thing that we need to remember is that in Kerala, I think from about 2000 onwards, there is a part of the total revenue receipt of the state goes to the local governments as development as well as maintenance fund. It is actually mandated as a certain percentage of the receipts, the tax receipts. Now, then there is of course the plan funds. 25 to 30% of the total plan funds flow into the local government. my own estimates show that if you take it as a proportion of the total revenue receipts, about 10 to 12% of the total revenue receipts of the state flows into the local governments every year. And they are free to spend it the way they like. Now, this is something which is, I think, you don't see this sort of a thing in other states of Kerala, other states of India. I think that also made a huge difference. That's why the infrastructure in the local governments in Kerala are of a level which you do not see elsewhere. I think this also played a very important role, right, Iqbal? Because you see the
Yes,
infrastructure. Yeah. So I think that's there was one question, very pointed question on this. I think that this could be a lesson for the other states if they can also do. In fact, in some way, Odisha has done it in the context of addressing cyclones. But they probably will have to do more.
Their cold control is also fairly good.
Yeah, fairly good.
And flood control.
Yes. I think with that we come to the end of all the questions. Is there anything else?
I was asking whether you can make the Kenneth Arrow articles available. Have you got a website? Put it there.
I think it should be possible, right, Achin? Hello, Achin?
Also, maybe we can upload them in the website. Yes.
Yes. The site, we can probably upload that. It can be made available. Absolutely no problem.
Yes, we can ask Subrata if he can facilitate that. That's
Yes. Subrata, shall we come to close the?
Yes.
There's one more question.
Yeah, please ask that question. It's addressed to whom? Hello?
Oh, somebody has, yeah.
Subrata?
Subrata, is there a question that we have missed? We can address that, or we can.
One last question about the possible role of Ayush.
Okay.
Well,
do you want to answer that?
In COVID, about COVID management.
Ayush, the potential. We have not realized the full potential of Ayush.
Actually, we have, generally speaking, I'm not talking about COVID. Basically, Kerala government is giving a lot of importance to Ayush systems of medicine, especially since we have a very vibrant Ayurveda system in Kerala. And but standardization validation is necessary, and therefore the Kerala government has established a Ayush Research Center in Kannur, which is about to function. So that we are trying to promote Ayush system of research in by establishment of this center. And but a large number of tourists come here for Ayush treatment, especially Ayurveda treatment. So the Ayurveda tourism is one area where we are trying to promote.
Yeah. Is there anything else, Subrata? You can only see the questions. You cannot see the questions that are asked in the YouTube and the Facebook. So here, what you could see is only the questions. But there are some of these questions which were raised do not appear here, but came from other sources. So we have fielded those questions also. I think with that, we fielded almost all the questions, and our panelists were very kind enough to answer many of them. So with that, shall we close the proceedings?
I think so.
Professor Achin, Peter Smith, and Dr. Iqbal for a very, very stimulating presentations and fielding, answering the questions. I hope the participants benefited from this exercise. Any feedback is most welcome so that IHEPA can, have other sort of similar sort of events. Thank you very much.
Thank you. Thank you all.
Thank you. Thank you. Thank you. Thank you.
Thank you.